thanks so much for having me. My name is Kate Demers. I am a practicing midwife here in Hamilton. I'm also an assistant professor in the midwifery education program. But in terms of healthcare, one of my major roles is as the lead midwife at a clinic called Crown Point in the East End of Hamilton, where we offer sexual and reproductive healthcare services. So everything from contraception to early loss to abortion care, menopause counseling, and some pregnancy and postpartum related care as well. Yeah, so I think of my role sort of in two ways. So there's the normal sort of midwifery work that I do. And in that case, we offer prenatal care, intrapartum, so care during labor for folks, and then postpartum care up to 6 weeks. And as a midwife, we really specialize in normal pregnancy and birth. So we're able to offer that. In Ontario and really across Canada, midwifery is almost in all provinces at this point. On top of that, the other work that I do is around that sexual and reproductive health care, where we're able to go in an expanded scope model. And what that means is that generally we have a really defined scope as midwives, and we've been able to find some spaces where there has been a lack of care in our community and been able to pair with one of the obstetrician gynecologists in our area and work under medical directives. So we provide care for things that typically wouldn't be in midwifery scope. So again, thinking about medication abortion, early loss, being able to provide that care using medication is not in our pharmacopoeia. It's not part of our usual scope. So we've been able to provide some additional care that way. Sets what I would say sets midwives apart is our ability to really offer care in the community. I know that there's certainly family doctors and other groups that provide community care, but it really is at the one of the core things that we do. We will care for people in their homes, both prenatally. We'll do home visits for the postpartum period. So after the baby's born, we really do see them in their home for a few weeks afterwards before they start coming into clinic, which is something that a lot of people appreciate, not having to bring their newborn back to the hospital or into the family doctor's office around we're around sick people. So we go and see them in their home for those first few weeks. And then obviously, or maybe not obviously, one of the tenets of midwifery care is really around providing care at home for home births. So while across the province, about 80% of folks will choose to have who are under midwifery care will choose to have their babies in hospital. The 20% who are still choosing home birth and midwifery care, we're able to provide that. And what I would say that does is it sets us up to be able to be excellent at providing care in multiple areas. So it means that even outside of our normal midwifery care, and when I look at my expanded scope, I'm really used to just grabbing a bag and going to somebody's place to provide care there if they're having barriers for access, if travel is difficult, if they have young kids and trying to bring them into the clinic is difficult. It also means that we do some work, we pair with Shelter Health in Hamilton, where we get to see folks in sort of unhoused situations, and we really can go out and provide care wherever they are. So I'd say that's a huge benefit to midwifery care, and something that we don't always see with other healthcare providers is the idea of how flexible and how easily we can travel. So midwives have people come in from lots of different ways. So often their primary healthcare provider, so their family physician will refer them and will get a phone call when they're pregnant that way. People are also able to self-refer. And with the self-referral, they just give our clinic a call and they're able to access midwifery care that way. Along those same lines, for our expanded scope care, we work in the same way. So we have multiple routes of entry. People will be referred from their family doctor. People will give us a call. They'll find us online. They'll come to us from just different areas, whether or not, again, it's their nurse practitioner, family doctor. Midwives will refer to us because we're outside of the scope. Oh, there are so many. I think one of the ones that gets portrayed often is who accesses abortion. And while we know that about a third of people over their lifetime will access abortion, we often think of either young folks or certain groups being the people that access abortion the most. And really, when we look at the numbers, what we find is that it's across the board. So yes, depending anybody at any age who can get pregnant can decide to access abortion, but often it comes around family planning. So having one or two and deciding that it's not the right time for the third. So when we look at the numbers, it's really not certain populations that are accessing abortion, but really everyone. And that again is spoken to in the numbers with how many people will access an abortion over their lifetime. I have been privileged enough as a midwife to work under a medical directive and provide medication abortion care. So in 2000, I want to say in 17, we applied. There was a call that went out asking for funding applications for expanded scope midwifery care models. And we paired with the Crown Point Family Healthcare team and the McMaster Education Program, looking at an expanded scope model. We, I think, made a pretty strong argument that folks in the East End of Hamilton have lower access and a lot of barriers to care, and we're successful in the application. And in the application, we identified a couple of areas where we thought we could provide this, where we could sort of improve access to care. So it was everything again from providing prenatal and postpartum care to people who weren't accessing, say, their family doctor through shelter health or other things that way, didn't have a family doctor, but also contraception care and abortion care came up as major needs, as well as menopause care. And so at that point, we developed a program. We paired with one of the obstetrician gynecologists in the area, and we were able to start providing medication abortions. And it was around the same time, actually, that mifegamizole, so the pills that we use for medication abortions, became available in Canada. So in 2015 is when mifegamizole was approved. Canada was an extremely late adopter to that. Across the world, we had seen it used much, much earlier. And then it took us about 2 years really to see it start to get used. So right around the time that we had opened our practice, we saw Mifi start to be used across Ontario, and we were able to start providing care that way. So what happens is folks again can self-refer, or family doctors. We've reached out to other community agencies that are aware of us, and people give us a call, and then we're able to provide for those under 9 weeks of care. There's a lot of places that are doing 9 or even up to 12 with medication. Right now, we're doing up to 9 medication abortion care. And we'll see everybody, or we'll see from anywhere from 0 to about 5 people a week, just depending on what the week is for care. Yeah, so the challenges are often around timing. A lot of the clinics, including us, tend to work more during business hours. And so asking somebody to take a day off for it, and then even if you're looking at the medication abortion, we usually recommend spending one day at home, then that can be difficult. There are time limits. I think the time limits are realistic, but in Hamilton, for even if you're looking at the therapeutic or the surgical or procedural option, they go up to about 16 weeks. And so sometimes around timing can be a little bit more difficult. If you're looking at the procedural option as well, you do need at this point somebody to drive you home. You have to take a day off work again at certain days of the week. There's always transportation barriers. So language barriers, I know we're able to get translators most of the time. Cost, luckily for most people, is not a barrier here. We are able to, as long as you have an OHIP card, your medication is free if you're going in for For a procedural option, again, that's covered. However, for anybody who does not have access to OHIP, so we think about our international students who are here with insurance, that's not always covered. Certainly folks that are here and that are new immigrants aren't always covered until their OHIP kicks in. So we see a lot of cases where cost can absolutely be a barrier. The medication is about $400, but that's not the only cost. Often there's blood work and ultrasounds. There can be costs associated with the visit itself, not at our clinic, but at the other ones. So depending on sort of your life situation, then cost can absolutely be a barrier in some of those as well. Yeah, I mean, we know that the further rural you go, the further north you go, that access to care decreases significantly. We know that you need to travel farther, and arguably it's that happens in communities that are urban as well. So in Hamilton, we see people who have to come in from Niagara really, really often. I would say access to care in the Niagara region is not well set up at all. So it is very normal for somebody even in rural or in urban areas to have to come and see us in Hamilton. Having said that, the further north you go or the further rural you go, you can often have to travel 2, 3, 4 hours for care. I mean, that's not just around abortion care. When we think about the folks that are pregnant and having to get come in, even like when they become term, they're flown in, they're taken out of their communities. We know that access to care in the north, especially in our Indigenous communities, has a lot of work that still has to be done. And we know that anytime that you have to travel or that you're working harder to get an abortion is almost always causing a delay. And well abortions are absolutely safe options. The longer you go and the further you are into your pregnancy, the less safe they become. And so the earlier access that you have to care, when we look again at medication, it's an extremely, extremely safe option, and really should be offered in any community. It should be readily accessible. I was sat on a panel with a couple of other providers, and one of them had been working in Manitoba and would do rotations to a fly-in community, and really talked about the how difficult it was to start offering medication there, even though we know how safe it was. And part of that was just around community resistance in the medical community because of the fact that if something went wrong, oh, what do we do? And really, if you miscarry and you're up there, what do you do? Like there are things in place that happen. And the other one was they were worried that they would be taken out of town if people found out that this was one of the services that they were providing. They were worried about the sort of the political and social ramifications. And what they did was they just started offering it quietly. And she talked about this, and that people, and what they would do was people came in and they were pregnant, they would ask, instead of saying, oh, congratulations, that's great, they would ask more questions about, is this planned? Were you thinking about continuing this? And then people were able to open up, and very quietly the community who needed to abortions became aware of what was going on, and that they've been working there now for years and years, and that people that need to access it find out that they're there and doing it without a lot of broadcasting. And so that's been a really interesting way for them to reach out into a more rural community. But we know that's not happening in the vast majority of rural communities. People really are having to travel. And we see provinces handle abortion differently. So some places their laws are more or less restrictive. We do not actually have a law in Canada. It's just between you and your healthcare provider. But what that does is it allows provinces to decide in a way about how it's offered. So there are some provinces where the only places that you can get abortion care is within the hospital, so they don't have private clinics. And but if you have to go into the hospital, then people again have to travel a little bit further. There's often a wait list or a wait time, and we don't see as many clinics that are open and offering that access. And in those cases, we see more restrictive abilities to access care across the country. When we look at internationally, we see about 60% of countries really have fairly open abortion laws. So your ability to get one based on the law is really around whether or not, one, you want one, and two, if there's a need either economically or physically or anything like that. So they tend to be fairly open laws, but we still see about 40% of countries that have restrictive laws. We know that restricting abortion care does not decrease the number of people that are accessing care. It just makes it more unsafe. And we know that worldwide that we see tens of thousands of people that die every year from unsafe abortions, and that we can drastically reduce that number simply by providing them in a safe and effective way. Yeah, so when people don't have access, and we sort of hit on this a little bit before, we definitely see them still accessing it, but they don't access it in a safe way. There have been a couple of things I would say that have come up in Canada more recently, that are helpful. So we have seen a couple of clinics open that will do what we call like a no touch, and so it does provide telephone or virtual care. And so if you're at low risk for an ectopic pregnancy, so a pregnancy outside of your uterus, and there isn't really any other reason not to be able to provide a medication abortion, they can actually have you sometimes go into a lab in your community or not require that lab work. You can do it with a pregnancy test. You can pick up the medication hopefully at a pharmacy near you. Sometimes it's around mailing, sometimes it's access at pharmacies for the medication that becomes the problem. But that's really opened up for those earlier abortions where we're able to use a medication. But when we see that not happen, we definitely see the rates of mortality go up. We see the rates of morbidity, so long-term health consequences or short-term health consequences go up. We also, I mean, we'll see larger numbers of family, like in families. And so we see economic issues where folks are having children that they weren't planning to have, and that has a huge impact on ability throughout their lifetime. So it's a real way to sort of have people not in the spaces, not being able to attend school or work as often as they want to, or do other things because they end up with larger families than what they would originally want or plan for. Yeah, wait time can be a huge problem, and again, the what we know is that the further along that you go in your pregnancy, the more difficult it is. And so, if we look again in Ontario for places that offer sort of abortions around that 20 to 24 week mark, there are really, really selective locations that are able to do that, and we the vast majority of people choosing an abortion will figure out that they're pregnant, know that they're pregnant, and access care a little bit earlier. But there are certainly times, and I personally know of folks that try to access it, say at just over 9 or 10 weeks, and we're like, no, sorry, we can't give you the pill. There's nothing you can do. But there is, and so they're not getting referred properly from their primary healthcare providers or from folks in the community. Pregnancy counseling places will full out lie around what access is. And so it puts people off. And once you're off, it's much harder to get into the locations that are offering later abortions. And that becomes, again, more complicated. The wait lists get longer, and you just sort of spiral. So early and easy access to abortion is the absolute safest way for that to be provided. In so each province will set its own sort of law guidelines around what happens. Here in Ontario, what happens is that we have clinics both like in hospital and out of hospital. However, again, the more rural that you go, the more difficult that access becomes, or even in some urban centers, there just hasn't been a large uptake on that. And that will differ from other provinces. Again, where if they're only offering in-hospital abortions, then we can see some problems with access to care that way. Internationally, about 40% of countries that have fairly restrictive abortion laws, and that just means that people are not accessing abortion in a safe way, and that's certainly where we see that maternal morbidity and mortality go up. So the difference is, payment. So how much it costs will be a difference, like whether or not the cost is covered, where you access it, how you access it, who is able to provide it. So one of the things that I haven't talked about yet, I did talk about us as midwives being able to provide abortion care under a medical directive in Ontario, and there's actually a couple of clinics that are doing that. But in other provinces, we've seen that midwives are actually able to just within their scope offer it. And it was interesting in the province of Quebec. What happened? I had just an interesting conversation with one of the midwives there about a month ago, and when the Roe versus Wade decision was overturned by Dobbs, so when Dobbs came through, the midwives in Quebec at that point had been working really hard towards changing their scope to be able to provide contraceptive care and specifically insertion and provision of care around IUDs. And what they decided to do was take all of that energy that they had been working like over a couple of years around IUDs with the Dobbs decision in the US, and decided like, no, this is the time. We have the political will. This is like a great time for midwives to really shift. And in about 3 months, they were able to look at like, how do we get this in place? How do we get training for midwives? How do we get our pharmacopoeia? How do we get our scope changed? And while that was like sort of like 10 steps forward and then two or three back when people started to realize what was going on and push back, they will over the next month be able to provide abortion care. And what that does is any healthcare providers who can provide safe abortion care just opens up access. When we have nurse practitioners, when we have midwives, when we have family doctors, when we have this whole group of people that do go out and provide other care, and we know that a medication abortion, again, is an extremely safe option. It can work really well, and that earlier access to care can make a really big difference. Anybody who can offer it can really go into communities. They're already in the communities. They're already trusted in the communities and can provide that care. So I think really what we need to do is open it up. When Miffy was first came into Canada in 2015, there were some really restrictive laws that were put into place around it in terms of who could provide it. And so you needed really special training courses that could only be offered by certain people. You had to take the first pill in clinic. You needed sort of an ultrasound here and there. And there were just these really, really restrictive laws that weren't supported by the outcomes. Like it was safe to do. None of that actually improved outcomes in any way. Of course, we all want to provide safe care, but it really just put up barriers. And so anytime that we're able to have healthcare providers offer this, and again, we're seeing that with virtual care in terms of the way that it's changed during COVID, more people are able to provide care on a broader basis because you don't have to be in the location. So I think that we're seeing some really positive changes, and that we really need to continue to work on that so that we're providing better care provincially, internationally, and then at a national level as well. So coverage will be based on province. In Ontario, if you have OHIP, you are covered both to go pick up your medication as well as for any procedural options. There are clinics that that can charge an administrative fee. It might run like $50, which for some people is absolutely a financial barrier and is worth looking into before you were to access a clinic about the cost around it. For folks that have insurance, it's really variable. So it depends, like anything else for insurance, on your insurance provider. And so that can mean that sometimes your tests, so if you needed, some people will get an ultrasound or need an ultrasound. Sometimes there's some blood work involved. For some people, depending on their blood type, they might have to get something called ROGAM. So there are some times where costs might be involved where your insurance will cover it or your insurance won't, and that is really like individual. We find that again, often like the blood work or other things will be covered, but that the pill itself, for some reason, insurance companies shy away from it. And in that case, there are some really great programs out there. And so people can access information through NAF Canada. And I would encourage anybody who's interested in abortion care or that abortion in general to become a member of the National Abortion Federation. They have really great training sessions. They have information very much towards providers. So again, you don't have to actually provide abortion care to become a member, but it does provide excellent information. The The other thing is that they will set people up. So if people need to travel, they help you figure that out. They have a list of everybody who can provide abortion, or a list of a large amount of the clinics, and so they'll figure out where you are in your area. There's also Choice Connect, which is an online service where you can go on, put where you are, how far along you are, and then again, they can match you with finding a provider. There is Action Canada, who does a lot of work for helping people. So for those folks that we see, say from the Niagara region, they will often help them get transportation. We've reached out to them on multiple occasions for folks that aren't insured, to help cover the cost of medication or other things. So there are groups out there, and then if you know somebody who's trying to access it, being aware of those, and certainly as a healthcare provider, reaching out to those groups can make a big difference in terms of access to care. So laws limiting access, again, in hospitals. So if you're not offering it as like in clinics outside of hospital, that becomes really problematic. Cost laws become really problematic. So when people have to pay out of pocket, um, the gestational age laws can become really problematic. So, depending on where you are, whether or not it will be offered in the province, or if it's not, you can travel out of province. But again, travel just becomes problematic in terms of delays to care, figuring out where you're going. Lots of people can't up and just leave their family for a couple of days. And so, when things aren't offered in your community, you're just putting up barriers that are unacceptable for providing good healthcare. Yeah, so I think this is a nice way to almost round things up in terms of talking about what midwives do. And I think one of the ways that we can improve care is really around being able to meet folks where they are. We really are used to working around, as most healthcare providers are, language barriers or transportation barriers. We can go out and see people where they are. We also are in multiple communities, and while in Canada, often our scope is more limited. We really do provide much more around pregnancy and post, and that immediate sort of 6-week postpartum care. We know that historically midwives really were the folks that people went to, and internationally, still in some places, are the people that are who people go to for reproductive health care. I think as midwives, we can do a much better job of working on expanding our scope. So, figuring out ways to provide contraception care, which really does lead into abortion care. If we think about it, we really can't disconnect those two. We see people right up to their 6 weeks, and so why are we not making sure that folks at that point are well informed and maybe starting the contraception that they need? And so we can, as midwives, really go into communities. We're already there. We can provide well-rounded care. We can make sure that people are getting access to contraception and abortion in communities where maybe there aren't other people offering it right now. See it everywhere right now, but I really just have to echo the idea that abortion care is healthcare. It really is something that will have an impact on every single person's life, whether it's through somebody you know or you yourself. And having access to that safe care makes a really big difference. It's really, I think we all need to take on responsibility for understanding where people can access care, how people can access care, and being able to be one of those, be somebody that, if when you are approached, that you actually can go ahead and provide information and help for folks, no matter where you are. It really can make a huge difference in somebody's life to have that supportive, supportive person that they can go to.